We'll go ahead and get started. Thank you guys for coming. CF, cystic fibrosis, truly expands all disciplines. Historically, pediatric providers have cared for the needs of patients with cystic fibrosis due to their shortened lifespans. But now CF patients rarely succumb to this disease in childhood, and they are increasingly seeking care from adult providers. Actually, the first CF patient I took care of 10 years ago, she was 27. Now she's 37, and last Wednesday she threw out the baseball pitch for the Detroit Tigers. So these patients are living longer. And we can now expect to see CF patients for decades after they turn 18. So cystic fibrosis is now really a disease for the internist as well as the adult pulmonary specialist. And these patients are increasingly being admitted to the general medicine floor. And I see Amber, and she's med peds. And so on med peds, pretty much during a pediatric residency, from your first day, you get exposure to patients with CF. And you get a lot of training on it. But with these patients living longer, you're going to see them more and more on the medicine floor. And so one of the objectives of this grand rounds was to really sort of increase our internal medicine house staff, internists, residents that are going to be hospitalists, kind of increase our familiarity with recognizing the needs and providing for inpatient management of patients with cystic fibrosis. Can everyone hear me okay? Okay. Well, here's an example of a patient that you may see. This is a 21-year-old male with a history of cystic fibrosis. He presented with worsening shortness of breath and cough associated with productive secretions. He was diagnosed with cystic fibrosis when he was 15 months old, and he has a history of multiple inpatient admissions for acute pulmonary exacerbation of cystic fibrosis. His most recent hospitalization was 3 years ago to the pediatric service. Sputum cultures then demonstrated methicillin-resistant Staph aureus, multi-drug-resistant Pseudomonas, and a Chromobacter. Past medical history significant for cystic fibrosis. He has a seizure disorder, portacath placement, as well as a G-tube placement. His medications are azithromycin, Dornase alpha, albuterol sulfate, ipratropium, fluticasone, his pancreatic enzymes, cholecalciferol, ferrous sulfate, ascorbic acid, as well as oxycodone and acetaminophen. So imagine you've just completed your residency, and this is the first patient they call you about as a hospitalist. Or you're the resident on call, and you're an intern. So this is kind of what you want to familiarize yourself with, the way this patient may present, just so you have an idea. So what is cystic fibrosis? It's a multi-system disease. It has an autosomal recessive inheritance pattern. It is due to mutations in the cystic fibrosis transmembrane conductance regulator, which is on chromosome 7, and this codes for a cyclic AMP-regulated chloride channel. What's the burden of CF? CF occurs in 1 in 2,500 to 3,500 white newborns in the U.S., 1 in 11,500 Hispanics, 1 in 14,000 to 17,000 African Americans, and 1 in 25,000 Asian Americans. So you can see it has a wide demographic. Now, when you look at the CFF registry, there are approximately 28,676 people affected in the United States with cystic fibrosis. And over half of those patients are adults now. And while 80 to 90% of CF is diagnosed in childhood, 10% is diagnosed after the age of 18. It's sort of your atypical disease. The median age of people with CF is about 18 years old. What about survival? Survival has improved. Between the ages of 2 and 20, female survival is a little bit worse. However, the median age for survival is about 39 years. It's not uncommon. I think the oldest patient I've seen was about 43 years old, but there are some patients that are actually in their late 40s. So a little bit about the pathophysiology. It's due to mutations in the CFTR protein. And this protein basically is a chloride channel in the epithelial membranes. Deficiency of this protein leads to pathologic changes in organisms that express the CFTR. in organs that express the CFTR. One organ in particular is the lungs. When we look at the airway, there's an abnormal mucus due to the dehydration of the airway surface layer from this deficiency. This causes impaired mucociliary clearance. The airway becomes colonized with multiple organisms, and then there's a sort of inflammatory sustained inflammatory response that's sustained to the pathogens in the airway, and that's why it's like a chronic disease, because it's ongoing. I don't know how well you can see this, but some of the clinical manifestations of cystic fibrosis, we think about pulmonary manifestations. It's chronic productive cough, sinusitis, bronchiolitis, asthma, colonization with Pseudomonas and staph, digital clubbing, atypical mycobacterial infection, and that's just in pulmonary manifestations. But when you think about GI manifestations, there's a pancreatic insufficiency, entity known as distal intestinal obstruction syndrome, vitamin deficiencies, recurrent pancreatitis, biliary cirrhosis, and then genitourinary. And this is an area when I mentioned earlier about the atypical presentations. There's a bilateral absence of the vas deferens, there may be male infertility, as well as the reduced female fertility. Other manifestations are pseudotumor cerebri and osteoporosis. So see, it really affects every discipline. Cystic fibrosis related diabetes, this is like the most common complication of cystic fibrosis encountered among individuals school age and older. Its prevalence among people with CF increases markedly with age, rising to almost 50% in those over the age of 30. Other complications are bone disease, depression, as well as joint problems. So how do we know there's a need for hospitalization? Well, many times the patient may recognize there's something going on themselves. They have a great relationship with the CF doctor. They may be at their CF visit and getting their PFTs done. Or some of them may just be visiting and end up in the ER just not feeling well. But some of the symptoms that we want to look for are increased cough. The cough has an increased frequency, duration, or intensity. Increased sputum volume. Is there a change in character of the sputum? Is the sputum a darker color? Also, patients may present with chest pain, anorexia, vomiting. Other signs are decreased exercise tolerance, new or worsening. We had a patient that could not continue to play soccer as much. And then some of your findings on your physical exam, such as increased crackles, wheezes, rhonchi, or tachypnea. And also new systemic symptoms, fever, respiratory distress, malaise, fatigue, poor appetite. Nutrition is very important. We'll talk about that later. But when we look at weight loss, like a greater than a 5% decrease from their baseline. Also, the spirometry, as I mentioned before, may show a greater than 8% decrease in their FEV1. They may have decreased oxygenation from their baseline. And then looking at the chest x-ray, they may have new abnormalities such as a new infiltrate, atelectasis, mucus plugging, or even a pneumothorax. So what's the rationale for treatment? Kind of just an overview. It's really based on the pathophysiology of the disease. As we mentioned before, the dehydration of the mucus layer in the airways. And it's guided by the microbiology of the airway. You have your chronic colonizers. It could be due to a viral infection, mycobacterium, as well as ABPA. And how do we know that we've successfully treated these patients? One is symptom resolution, and also looking at their PFTs for recovery of lung function. Now, CF is unique, and there are special considerations, such as when these patients are admitted, what type of access do they have? I think our patient has a portacath, the one I mentioned before. Infection control is a big issue with CF patients. Chest physiotherapy, what's going to be their access to calories? Again, nutrition is very important. IV fluids, which IV fluids are we going to give? And again, these are adults. You have to remember your pregnancy testing as well. What about ICU considerations? The patients have gross hemoptysis, such as greater than 250 cc's. You see the patient in the ER and they're in significant respiratory distress. I think our guy was only on 4 liters but we'll talk about that in a minute, but significant respiratory distress, or if they're requiring antibiotic desensitization. And then sort of an overview of therapies. There's going to be, in general, oxygen, antibiotics, airway clearance therapy, nutrition, as well as a bowel regimen. These are all important things to think about when they're being admitted inpatient. So our patient from the beginning, this is his physical exam. His temperature is 37.5. He had a heart rate of 100 beats per minute. Respiratory rate was 20 to 22 breaths per minute. Blood pressure was 100/70. His oxygen saturation was between 88 and 90 on 4 liters of nasal cannula. In general, he's alert and oriented ×3. He is tachypnic. He's dyspneic. The skin, he's diaphoretic. There's no rash or lesions. HENT was unremarkable. Respiratory exam, he had diffuse rales in all the lung fields, but there's no wheezing and no stridor. Cardiovascular exam, he was tachycardic with a regular rhythm but no murmur. His abdomen was soft, non-tender, wasn't distended. The PEG tube was placed and did not appear to be infected, and there was no hepatosplenomegaly. Lymphatics, there's no cervical axillary lymphadenopathy. And extremities, I think our guy was only 20, but he did not have any clubbing, cyanosis, or peripheral edema, and did not have any focal neurological deficits. So this is an example of a chest x-ray that you might see in a patient with cystic fibrosis. One of the first things to notice is that there's a hyperexpansion of the lungs. Also, you'll see that there's upper lobe bronchiectasis, as well as mucoid impactions. And if we take a closer look, bronchiectasis is a primary sign of cystic fibrosis in the lung disease. Usually develops in the upper lobes, and it presents as sort of cystic lesions containing air fluid levels. And when we look at it on CT, sorry guys, excuse me, you'll see the sort of signet ring appearance, what they call a signet ring sign. So those are the findings of bronchiectasis in cystic fibrosis. So one of the nice things about the EHR is that there's a CF order set. So just kind of looking at from the beginning, you do your admit orders. Also, even though the median age was 39.3, you still may need to have the discussion about do they want to be DNR or not. Many of these patients may be on their second lung transplant, have a severe decline in function, and although they're young, you may still want to have that conversation. Some of the other places, this is where you would document on admission, like our patient had a portacath. You would want to place that here. In general, vital signs. You can specify the frequency. A lot of times we notice that it's kind of done Q shift, but you as the physician can order it kind of as you see fit. And I think it's good initially to have closer monitoring. So with this screenshot here, what type of isolation precautions do we want in cystic fibrosis? Well, the infection prevention and control guidelines from the 2013 update, ideally you want patients with cystic fibrosis to have a private room. You don't want to cohort, say if you have 2 patients with cystic fibrosis, they really shouldn't be in the same room. You want them to have a private room. Hand hygiene is very, very important. One of the single most important things that we can do, alcohol-based or antimicrobial soap and water. Also contact precautions. The 2013 update said every CF patient you should wear a gown and glove regardless of what their sputum culture shows. And then if you think it's viral or something transmitted by a droplet, you want to make sure they're on droplet precautions such as adenovirus, rhinovirus, influenza, or mycoplasma. What about what type of diet do we want our CF patients to have? The standard diet for a CF patient is going to be a high-calorie, high-protein diet. I know we don't order that a lot here, but that's what we want our CF patients to have. And the optimal BMI for for adult CF patient over the age of 20 is 22 for females, and it's 23 for males. In a CF patient, or a patient with cystic fibrosis, a BMI less than 20 is indicative of malnutrition. So we saw that our patient was on a number of medications in the beginning. So we want to continue his home medications, especially his pancreatic enzymes, as we saw on the first slide. Nursing assessments. Nutrition is very important, as we mentioned, and you want the nurses to get an actual weight and height. These patients may be in for a long period of time, and it's just good for them to see that they're gaining weight and they're not losing weight. So it's not the reported one. You actually want them to measure it. Also, a smoking history. It's very important that that we address this as well, because these are many times young adolescents that have decided to smoke. So it's not a good idea with cystic fibrosis. And then a lot of places have immunization history that's nurse-driven, but as a physician, we also want to make sure to see what immunizations they've had. Now, respiratory interventions. If our patients are satting less than 90%, we want to go ahead and start them on supplemental oxygen, but also confirm this with a room air ABG. To get a room air ABG, to make sure you want to see if they're meeting criteria for ICU. You want to see what their CO2 is like, just to see the extent of their hypoxia. Okay. Now, cystic fibrosis management is really a multidisciplinary approach, and this is a time where we really sort of lean heavily on the ancillary staff, especially the respiratory therapist. Many of the respiratory therapists have great relationships with our patients that are admitted with CF. They've probably have seen these patients since they were children, a lot of them, and they can provide valuable insight as to what was good last time, or what you think may help you this time, and they're going to see this patient sometimes 4 or 6 times a day, and so they'll do the exam probably more than we will, and so it's really good to build that relationship with the respiratory therapist. And then you want to review their airway clearance therapy at home to see how compliant they are with, maybe they have a vest at home, or what are they using to clear their airways at home. And again, respiratory therapy can kind of help you with this. And while they're inpatient, you want to order mechanical CPT for them, or hand CPT, which the respiratory therapist does. And again, a lot of this is sort of based on the history of what they did before. And remember, CPT usually follows your nebulized treatments. As far as respiratory medications, you want to order your albuterol and your protropium. It's usually 4 to 6 hours. It's usually TID to QID, and if they're not having a major exacerbation, you can just do it kind of during those waking hours. As far as your dry powder inhalers, those aren't really used during a hospitalized CF admission. And for our patient, we continued his Dornase alpha. And again, consults. So consults in cystic fibrosis, as I mentioned before, is a multidisciplinary approach, and it's going to be very important. Of course, the pulmonary doctors, a lot of times the pulmonary doctors will already know that the patient is coming, but if they don't, get pulmonary involved. Endocrine, especially if a patient has a new CF-related diabetes, or if their blood sugar has not been in control. If your patient presents with hemoptysis, major hemoptysis, you want to do your consult to interventional radiology as well. Also, a psychiatry consult. This is the median age was 39.3. A lot of these patients have depression, and you may need psychiatry to help you manage that. Our patient was on oxycodone, if you noticed at the beginning, but if there's a concern for drug abuse, you want to screen for that and talk to psychiatry about that as well. All right, go ahead and get your comprehensive chemistry panel. You want to pay attention to the LFTs. It's not just CF is not just related to the lungs. And look at the previous labs. These patients are on a lot of medication, so you want to see what their creatinine is doing. When we look at cystic fibrosis labs specifically, as far as like an IgE or vitamin A, again, you're going to talk with the pulmonary doctor, but if these patients are going to be here for a while and they haven't had that done, go ahead and do it while they're inpatient. Daily labs are usually not required. Also, drug levels. Talk with pharmacy, see what the protocol, or with ID as far as a protocol for your tobramycin or your vancomycin troughs. Okay. A lot of places there's a sort of a pharmacy consult team that'll help you manage that. And what about our microbiology? To start with, we want to go ahead and order a sputum culture, especially if they haven't had it done within a week or so of admission. The mucoid strains of Pseudomonas, they're slow growers, so it may take a while to see those. Blood cultures are not routinely done for CF patients, but if the CF patient is presenting with high fever, or if you suspect a line infection, go ahead and get a blood culture and culture the venous access. And again, imaging, you always want to get your chest x-rays, your PA and lateral. It may have been done in the ER, but you still want to go ahead and, if it hasn't been done, go ahead and get it. And then you want to repeat it in about 2 or 3 days to see what progression has been made, and also at the end of your antibiotic course. If there's gross hemoptysis or significant changes on your chest x-ray, then consider getting a high-resolution CT scan. Remember, CF affects the GI system as well, so if you have a patient complaining of bloating, cramping, constipation, decreased bowel movements, go ahead and get your abdominal radiographs as well. And what about EKG? Patient is tachycardic, heart rate greater than 110. We want to go ahead and get your EKG, look for arrhythmias. Remember, they're on a lot of medications, so you want to take a look at see if there's prolongation of a QTC greater than 120 milliseconds. And then what about spirometry? You want to repeat that every 7 days while they're on IV antibiotics. And also, remember, you're working with the pulmonary doctor if you're in a place that has the pulmonary consult team on site. And then, as we mentioned before, your ABG, if a patient is satting less than 90 and you need to put them on oxygen, or if their CO2 on a chemistry panel is greater than 37. So how do we know which antibiotics to choose? Well, one thing we're going to do, and there's a list of some of the antibiotics on the order set. Sorry. So remember that there's several bacterial species identified in the respiratory secretions. So trying to select an antibiotic that covers all the isolates at one time may be difficult without putting the patient on a large number of antibiotics, which we don't want to do. So I'm so glad you're here, Dr. Shai, by the way. Thank you. But remember that these patients, they frequently carry the same bacteria for a long period of time, and their past culture results may be used to guide their antibiotic choices. And most of the CF patients are in what's called the CFF registry. And one of the guidelines is that when they go to their CF clinic, that they have their cultures performed sort of every 3 months. And that the idea was that when they do get admitted, you'll have that data readily available for you to use, which I think is a pretty good idea. So here's a graph of some of the bacteria that are prevalent in the respiratory secretions from patients with CF. And if we look between the ages of 18 and 45, just kind of starting at the top, you have Pseudomonas aeruginosa, then there's Staph aureus. You also have your multi-drug resistant Pseudomonas, as well as your methicillin resistant Staph aureus. You have your multifilia, as well as your Burkholderia. The ones that are associated with a worse prognosis and higher mortality are your Pseudomonas, your methicillin resistant Staph aureus, and your Burkholderia. Cepacia complex. So looking back at antibiotic selection, we want to target at a minimum any mucoid Pseudomonas aeruginosa and Staph aureus. You treat Chromobacter species if it's present. There's some controversy about that actually in the pulmonary literature when I was reading, but if it's present, you want to try to go ahead and treat that, as well as the multifilia. You want to try to treat that, but you don't want to place so much emphasis on that you're not getting the proper coverage for Pseudomonas and Staph aureus. So this is sort of a rough guideline of which antibiotics you want to choose. If it's Staph aureus, you want a methicillin-sensitive Staph aureus. You want to use your cefazolin or your nafcillin. If it's methicillin-resistant Staph aureus, you want to use your vancomycin or your linezolid. So for Pseudomonas, you're going to choose one of the following: your piperacillin, tazobactam, your ticrocillin, clavulanate, ceftazidime, cefepime, imipenem, celastin, or meropenem. You'll choose one of those, and either Cipro, this is all IV, Cipro, fluoxetine, tobramycin, or amikacin, or colistin. This is a second-line drug that may be useful when the Pseudomonas demonstrates in vitro resistance to all aminoglycosides, or the aminoglycosides were not working. So what if you have methicillin-sensitive Staph aureus and Pseudomonas? Same antibiotics for Pseudomonas as was shown previously, but you're not going to use ceftazidime because that has poor activity against Staph aureus. And then if you have methicillin-resistant Staph aureus and Pseudomonas, the same antibiotics for Pseudomonas before, but this time you'll use vancomycin and linezolid, so ideally it'll be 3 antibiotics total. So this is culture and sensitivities from one patient's in BAL. You'll see this patient had a multi-drug resistant Pseudomonas that was susceptible to colistin. And he also had a coagulase positive staph that was susceptible to vancomycin. So what's the duration of treatment? So in one study, it showed that the peak FEV1 was achieved at about 8.7 days, but they still continued to treat for about 13.5 days. Another study showed that they looked at over 1,000 exacerbations, and it showed that most improvement would occur between 8 and 10 days. And then this last study, they looked at, they continued the antibiotic treatment beyond 14 days. And the care team, the FEV1 sort of did not improve any further, but the symptoms continued to improve up between 14 and 21 days. And actually, I had to do a peer-to-peer. We had a CF patient that was admitted. The doctor from the insurance company called, and he was saying, why was the patient hospitalized for so long? So I said we were co-managing with pulmonary, and so he cited the first 2 studies, and the pulmonary doctor cited this last study as far as the symptoms improving between 14 and 21 days. And they ultimately paid for the admission. So one of the complications of cystic fibrosis is hemoptysis. So what are the admission recommendations for if your patient presents with hemoptysis? And I think we had this on the floor recently. Initially, you want to stop any NSAIDs. You want to go ahead and stop those. You want to hold a nebulized hypertonic saline. Go ahead and give them vitamin K, because remember, cystic fibrosis, there's a malabsorption, so they may be deficient in vitamin K. And if you suspect that there's a pulmonary exacerbation, go ahead and start treatment for pulmonary bacterial colonization. Again, you're not lone rangers when it comes to cystic fibrosis. It's a multi-team approach, which is really great. So discuss with pulmonary. Some of the things I've noticed the consult service wants to know, like what specific questions do you have? So you want to ask them about, with this patient with hemoptysis, do we continue the airway clearance routine? Do we continue their bronchodilators or pulmozyme or inhale antibiotics? How do we manage that in patients with hemoptysis? And if you're, let's say you just graduated, you're a hospitalist out there by yourself, you're waiting for the pulmonary team to call you back, go ahead and hold the pulmozyme first. Consider taking off one modality at a time until someone can get back with you from the pulmonary service. But if it's massive hemoptysis, contact pulmonary service, the bronchoscopy lab, the ICU, interventional radiology. Get everybody on board in case the patient acutely decompensates. Also, you want to withhold the BiPAP, airway clearance therapy, and other inhaled medications, and of course your NSAIDs. But go ahead and give them the vitamin K. Another complication is a pneumothorax. A large pneumothorax, they should be admitted to the hospital. Have a chest tube placed. If it's the first pneumothorax, they do not need to undergo pleurodesis. If it's the recurrent large pneumothoraces, they are going to have undergo pleurodesis. And there's really currently, according to the 2014 recommendation, there was no consensus on the issue of antibiotics for pneumothorax. BiPAP should be withheld from patients with a pneumothorax as long as the pneumothorax is present. I used to do a grand rounds on the medical hazards of air travel, and one thing that would come up is should patients with pneumothorax fly? And they should wait at least 2 weeks until it's resolved before they're able to fly or lift weights or even perform spirometry. Your Some of the mechanical airway clearance methods should be held, such as your intrapulmonary percussive ventilation and your positive expiratory pressures. And there was no consensus on the chest or on the vest or CPT. But also, as far as your inhaled airway treatments, if it's causing a worsening cough and the patient has a pneumothorax, go ahead and stop it and talk to the pulmonary doctors and see what else they recommend that you do. Another complication, and I put this in here because this is actually seen more commonly in adults, is the distal ileal obstruction syndrome. Basically, you have, remember I said the abnormal mucus, it's dehydrated, so the intestinal contents either completely or partially block the small intestine. This is usually located at the ileocecal junction. Your patient may complain of a sort of progressive abdominal pain, usually right lower quadrant, and sometimes you can feel a right lower quadrant mass. Remember to keep a differential in mind as well. If a patient has an incomplete DIOS, then usually make sure check the electrolytes, give them oral rehydration as well as osmotic laxatives. If it's complete, you're going to treat them with hyperosmolar enemas. And again, if your patient has signs of peritonitis and they're complaining of this crampy pain with the peritonitis, go ahead and get surgery involved. So this is the X-ray of what the DIOS would look like, and if you see the arrow here, you have this sort of bubbly, granular appearance in the right lower quadrant there. And this usually co-occurs with constipation. So what about discharge planning? Usually the CF doctor will kind of make the decision if the patient's ready to be discharged. Also, you have some input as far as how is every patient responding to therapy? What are the compliance issues at home? Then remember I said that some places the immunization is sort of nurse-driven. But at discharge, you want to think about what immunizations you're going to give. CF patients should have, of course, the influenza vaccine for all CF patients. This is an inactivated vaccine. And pneumococcal vaccine. It's recommended for all patients with CF, although the most common cause of morbidity is Pseudomonas. The risk-benefit ratio they found was high, so they said go ahead and the recommendations that you give the pneumococcal vaccine. So for those of you guys that are graduating and managing on the floor, these are just a few pearls to kind of remember. CF is a progressive genetic disease. It's marked by episodes of pulmonary exacerbation. Remember, it's now a disease for the internists. These patients are living longer, as well as the adult pulmonary specialists. Airway clearance, nutrition, and antibiotics are key elements. You want to continue your patient's usual home medicine, especially antibiotics that they're on at home. Azithromycin is a common one. And then remember when you think about treatments to promote airway clearance, such as your bronchodilators, your mucolytics like your Dornase alpha, your mucus hydrating agents, your inhaled antibiotics, as well as mechanical clearance. Remember to give CF patients vitamin K for hemoptysis. And then think about the airway effects when you're considering treatments for hemoptysis or pneumothorax. Like how am I treating this, and how is it going to affect the airway? Whenever you think there's a change in their pulmonary symptoms, remember have a low threshold for starting antibiotics. Pseudomonas is treated with 2 agents with different mechanisms of action. The distal ileal obstruction syndrome, that's more common in adults. And the initial management of that is you want to correct the electrolyte abnormalities, give the patient fluid, and then use your osmotic agents. And the last thing is patients that are on that have cystic fibrosis related diabetes, do not put them on a calorie restricted diet. Thank you. So this is where I was this morning. She broke her arm and we had to go for our follow-up visit to the ortho clinic. Thank you.